So Niels is Professor of Data Science and Healthcare Improvement at this institute, which I'm sure he'll explain, at the Department of Public Health and Primary Care at the University of Cambridge in the UK, where he leads a programme of research to develop and evaluate digital innovations to support improvement in healthcare. Niels has a global reputation for his work on data-driven informatics for healthcare improvement, health data science, clinical prediction models, and CDS. He has a background in computer science and artificial intelligence. He was president of the Society of Artificial Intelligence in Medicine until 2017, and he led the Greater Manchester Connected Health City, which was part of a £20 million government investment to establish a learning health system in the north of England. He's authored more than 250 peer-reviewed scientific articles and has a number of editorial roles on various journals. So, Niels, we look forward very much to hearing from you now on risk prediction models.
Thanks very much, Philip. And it's great to be here. Thanks so much for the opportunity to speak. Let me start by sharing my screen. So I hope you can see this all right.
That's perfect.
Very good. So I'm going to talk about risk prediction models and basically talking about the entire journey from development to implementation and impact of those models. And one of the things I'm going to say is that we've got some issues towards the end of that journey, the implementation and impact side of things. So Philip already told you a little bit about myself. So I was trained in computer science in Utrecht. I'm Dutch originally, and then worked for more than a decade in Amsterdam at in the teaching hospital there of the University of Amsterdam. That was a really useful experience to appreciate how challenging it is to make changes in such a complex healthcare organization. And I think that also shaped my research interests. So in 2014, I moved to the UK, to Manchester, to become Professor of Health Informatics there. And 2 years ago, I moved to Cambridge, where I'm based now in the medical school. So in terms of topics, and I look at in my research, ambient voice technology, clinical prediction models, healthcare quality and safety, clinical decision support, you can see that computable biological knowledge is not in that list. But Philip convinced me that it would still be useful and interesting to give this talk today. And on the right-hand side there's a couple of books that I've been recently reading, currently still finishing Ian McEwan's book, What We Can Know. It's phenomenal. If you're looking for a good novel to read, I can recommend that. So I work at this institute, the Healthcare Improvement Studies Institute. And what we do is create a credible and actionable evidence base for healthcare improvement and innovation. And in my group, in my work, the focus is very much on innovation using digital technologies and AI. We are funded by the Health Foundation. So in this talk, I'm going to talk about risk prediction models. So I'm going to start with just a brief introduction to get us all on the same page, what we mean by that, what risk prediction models really are. Then we're going to talk about three challenges. So the first is global versus local models. The second one is prediction under intervention. And the final one is implementation and impact of prediction models. So prediction is something that has fascinated people basically in all times. So if we go back to classical history, there's obviously the Delphi oracle that would tell people what the future would hold for them. And later in Rome, the Sibylline books, if you know that story, was also all about, knowing the future. And if you know what the future holds, that enables you to do better decision making. So that hasn't changed. Obviously nowadays, it's not the Delphi oracle or a set of books, it's the computer that we worship, but we're still trying to do the same thing. So a prediction model is a model that takes a set of predictors, and typically those would be relevant characteristics of the person for whom we are making a prediction. So things like age, sex, ethnicity, diagnosis, comorbidities, measurements, genetic markers, things in the person's environment, lifestyle factors, you name it. And then it uses a supervised learning model that produces probabilities. So that could be a logistic regression model, it could be a Cox regression model, could be random forest, could be deep neural network. There's many different options there. Yeah. And the model produces a risk estimate, so a conditional probability of an outcome. And that's what we call the risk. And the outcome of interest would typically be something that we're trying to avoid. So for instance, disease onset, a treatment complication, death, etc. So this is a form of supervised learning. So what that means is that we develop this model, this prediction model, using training data. And in the training data, or along with the training data, we will have labels. So those labels tell us what the outcomes were in the training data. We've got an estimator outcome that produces the actual model. And so that model, we could say, is the computable knowledge that is formed in this process. And that is then taken to the operational phase, where we use it to make predictions for new patients. So there we've got new data, and the model is then created, is used to create predictions, risk predictions. Typically, we predict into the future, so it's important to realize we've got a window. There's a time where we make the prediction. We will refer to that as time zero. There's things from the past that we will use to make the prediction. So all our predictor variables refer to things that we know at the time of the prediction. There's a prediction window over which we are making the prediction with an associated prediction horizon. It will depend very, very much on the type of problem setting that we're looking at, what the length of that prediction horizon will be. So in acute care, we're typically looking at 24 to 48 hours. Sorry, it says 28 tablets, should be 48. We also have a lot of prediction models, for instance, looking at hospital readmission. What's the risk of being readmitted once you've been to the hospital? Typically, we're then looking at 1 to 6 months. But there's also models for chronic disease prevention. We're going to see one later on, actually, called Q-risk. And then we're typically looking at 5 to 10 years. So very, very different. What we typically do when we use these models is a form of threshold-based decision making. So we've got a model that predicts the risk of something that we're trying to avoid, like disease onset or hospital readmission, etc. And then if that risk is above a certain threshold, we're going to try to do something about it. So we're going to take preventative measures. And that assumes essentially that above that threshold, the benefit of doing that will always exceed the potential harm that comes with treating patients. Because whatever we're going to do, there's always going to be some risk of harm. If, for instance, if we prescribe statins to prevent heart disease, then there is going to be a risk of side effects and therefore harm. But we assume that if the risk is very high of getting heart disease, then it is better to treat than to not treat because the benefit will exceed the harm. These models are typically assessed using a number of measures of validity. The most well-known is the area under the ROC curve. So we've seen it already in a number of presentations today. A slightly, perhaps less well-known, but I personally believe equally important measure is calibration of the model. So do the predicted risks coincide with actual risks? And then finally, there's something that is perhaps even a little bit more obscure than that, but again, I think extremely important, which is net benefit. And that tells us if we compare the model with the extreme strategies of not treating anyone versus treating everyone, how does the model behave compared to those two extreme options? And that's what we call net benefit. There exists very good guidance on how to develop these models and how to report the development and validation of these models. So there's something called the tripod plus AI statement. Originally, it was the tripod statements that appeared about 10 years ago now or so. And then last year in 2024, there was an update of that statement, and it's now called Tripod Plus AI. And it's guidance for how to report prediction modeling studies and also prediction model validation studies. And this can be used both for studies that use regression models, so statistical models, as well as models based on machine learning. And that's the plus AI bit that was added last year. And the guidance typically asks authors to report things like, what was your study population? How did you prepare the data? What were your outcome? What were the predictors? What was the sample size that you used, and how was it justified? Which analytical methods did you use? Was there any class imbalance? How did you apply fairness measures? What was the model output? Things like that. So this is widely used and I think very, very good. And it also indicates how well established the field is, because this is really beyond dispute, I would say. We can think of prediction models in terms of learning health systems as follows. So if we develop a prediction model, we would typically start with extracting or collecting data that we're going to use to develop the model. And then once we have developed the model, we would validate the model using some of the measures that I've mentioned previously. And then the next challenge would be to embed that model into clinical systems. Once we've done that, we can implement the model in clinical practice, so we can start telling people that it's there and encourage them to start using it in their clinical decision making. We might have to train people or provide guidance on how to do that. And based on that, we can study user experience and, for instance, acceptance of clinicians of the model. And finally, we can study the impact that the model has on processes, so decision making, for instance, and outcomes. So does this really help, for instance, to prevent the thing that we're trying to prevent? So that's how these models link with the learning health system. We're going to get back to this later on in the talk. So as I mentioned, we're going to talk about 3 different challenges that I think are important in this area at the moment. And the first one is global versus local models. And let me try to explain to you what I mean by that. And I'm going to use an example of a study that we published in the European Heart Journal last year. And this was about prediction of sudden cardiac death in patients with myocardial infarction, so a heart attack. So people who have a heart attack will typically develop a bit of scarring of the myocardium, so the heart muscle. And once you have that type of scarring, there's a risk of developing arrhythmia. That's because the electrical signal will not travel well, basically, across those scars. And then arrhythmias of certain parts of the heart, especially the ventricle, are very, very serious and risky and could kill you in a couple of minutes. Now, this is not something that happens very often, so there could be spells of arrhythmia. But overall, from all the patients who've had a heart attack, myocardial infarction, only 1% or so would actually die of ventricular arrhythmia. Now, we can prevent this by implanting an ICD, an intracardiac defibrillator. But given the fact that only 1% of patients would actually need this is overkill, right? So you wouldn't want to do that. You want to basically give it to only the patients or small percentage of patients who would probably need it and not to all those others. So we need to predict who's at risk of sudden cardiac death. So what we did is we brought together 19 different data sets from a large number of different countries, mostly European, but also we had data from the US, from Japan, and from Israel. And we pulled those data together, had a very large data set of more than 200,000 patients, and analyzed those data. And we analyzed the data using 5 different prediction modeling methods, coming both from statistics and machine learning. So you see them on the left-hand side here. So the gray dots in the graph is a Weibull regression model with just one predictor, left ventricular ejection fraction. So that's a very, very simple model, basically. But we also had, for instance, the orange one, deep hit. That's a deep neural network. So that's a very, very complex model, use 76 predictors. Now, on the right-hand side, and I appreciate this is a very busy graph, but the first thing that I think is important is that the differences between these models, between the colors basically, are very small. And typically, it didn't really make a difference whether we use that very simple Weibull model or the deep neural network. And then the second finding um, was that most of these models were not predicting better than chance. So the zero point 0.5 vertical line here is predicting as good as a coin toss. And in most cases, the 95% confidence interval included 0.5. So we're not doing very well here. Now, all these validations here are based on what is called external validation. So we had 19 data sets, and what we did is we left out one data set. So if we look at the top row, for instance, it says ATMS, that's for Artemis. We left out the Artemis data set. We developed models on the 18 remaining data sets and then made predictions on Artemis. Now, in case of Artemis, this worked really well. So we had very high values there, 0.9. But for most other data sets, it was basically a disaster. So we got very poor performance. And this is actually not unusual. So prediction models very often perform poorly in external validation. Here's a calibration graph from a study published in 2019 from Ben van Kalster and colleagues, where they also found that when externally validating a prediction model, which was initially doing a very good job, but when it was externally validated, it was very poorly calibrated. Now, in this case, there's the possibility to do something about that because you can relatively easily recalibrate a given model. You can update it using local data. The question obviously is, when should we do that and when should we not do that? I think the upshot of these findings is that there are basically no universally valid prediction models, which is a disappointment, but it's also understandable because these models are very different, for instance, than drugs. So we have universally valid drugs in the sense that they work in everyone, every single person on the planet. But for models, that doesn't seem to be the case. And that's because they tend to be very dependent on the context in which they are being used. So they depend on patient populations, measurement procedures, clinical pathways, and the wider cultural context in which they are being used. And all these things tend to vary between different geographical locations and clinical settings. So we have to expect this heterogeneity in model performance between locations and settings, and there are no universally valid models. And we can do something about it, as we saw in the study from Ben van Kalster. We can refit models or recalibrate them every time we deploy them in different places and settings. However, that also comes at a price, right? So if we compare these two approaches, suppose that we go for global models, like we were trying to do with sudden cardiac death. We've got an economy of scale. We've got something that is very efficient, right? We develop a model once and we deploy it everywhere. And this is also attractive for regulators because they only have to look at one model and decide whether they believe it's allowable to use that model in clinical practice. The problem is, as we saw from the examples that I gave you, these global models tend to perform very poorly in different settings. So we've got basically a model that doesn't work. If we go to local models, then we've got the big advantage that they can adapt to local settings, but this is very inefficient, right? Because we're going to have this enormous amount of different models, which is quite problematic as well for rare outcomes where we need to pull large data sets together. It's also problematic for data-hungry methods. Again, there we need very large data sets from multiple sites. And it can also lead to inconsistent care because the model that is used here is different than the model that is used somewhere else. So that also means that, in one hospital, the decisions could be different than in another hospital where they use a slightly different local model. So I think this is at the moment an unresolved challenge. So this is the first of my three challenges, finding the right balances between global and local models. And I don't think at the moment we've found a way to do that. So that's perhaps something for you guys to think about. Let me go to the second challenge, which is prediction under intervention. And now I'm going to turn to a model called QRisk. And this is the model that is used here in England, or in the UK actually, to predict the risk of cardiovascular disease. So the risk of having a heart attack or a stroke in the next 10 years. And it's recommended in the NICE guidelines, the clinical practice guidelines that are used in primary care in the UK, to consult this model whenever there is a GP believes that someone might be at risk of a cardiovascular disease. And we've used the model here to enter the findings, the data, sorry, for patient Joe. And patient Joe is a 50-year-old male. He's white, he's a heavy smoker, he's overweight, he's got type 2 diabetes, and he's got hypertension, elevated blood pressure. So we've entered that on the left-hand side. And this is what QRisk then says. So Joe has a 17% risk of a heart attack or stroke in the next 10 years. That is very, very high. And according to the NICE guidelines, Joe's GP should start treating him basically immediately with statins to reduce that risk. Now, we could also consider to put Joe on blood pressure treatment. And we can actually indicate in the interface that we're going to put him on blood pressure treatment. And suppose that, so initially his systolic blood pressure was 130. Suppose that because of the treatment, it would drop to 150. What would happen to Joe's cardiovascular risk? So if we now run the model again, we find that it is 19%, 19.1 to be precise. So Joe's risk just went up. So I've got a question for you. Why did Joe's risk go up? We were treating him with antihypertensive treatment, blood pressure lowering pills, which should be a good thing, but in fact, it wasn't, or it seemed it wasn't. So why is this? Is this because those pills aren't really working? Is it because the pills work, but the damage to his arteries had already been done and therefore his risk is bound to go up? Or is it because the model is not predicting what would happen if Joe were given blood pressure treatment? Just going to pause for a second here and see if there's anyone who would know this. I don't think I can see the chat from where I am. Oh, maybe I can actually. Philip Scott says C. Philip, why is that? Why is it C?
Uh, because it's based on data of what happened from people who were already on blood pressure treatment.
Yeah, I think that's right. So why is the model not predicting what would happen if Joe were given blood pressure treatment? Yeah, the reason is that we're conditioning on people who were given blood pressure treatment, and that means that we're basically looking at everyone who previously had hypertension. Otherwise, they wouldn't have been given that treatment. And previous hypertension is an important confounder here. It's not one of the variables that we use as a predictor, but obviously by selecting people on blood pressure treatment, by ticking that box, we are conditioning on previous hypertension. And that's a major risk factor for cardiovascular disease. So that's the reason indeed that we see that Joe's risk is going up. The pills still work and would reduce his risk, but that confounding factor, the previous hypertension, is so much more important and has such an enormous effect, much more actually than the pills, that the net effect of the two things is still a risk increase. We previously published a paper in Annals of Internal Medicine that's actually just a couple of months old, where we looked at the various ways in which confounding and other causal elements like colliders and mediators can actually play an important role in prediction. And this is, so we call this causal blind spots, because historically people have always said prediction and causal inference are two completely different things. When we do prediction, we don't have to think, we don't have to worry about causality. And what we argue in this paper is that that is actually not true. And the results that we get from prediction models can be quite misleading and confusing, as we saw in Joe's case. Because if we do not take account of the causal structure that sits behind the data that we're analyzing. And this brings me to the topic of prediction under intervention. And this is something that one of my former colleagues in Manchester, Matt Sperrin, has worked on a lot and is still working on. And basically the idea behind prediction under intervention is that we merge methods from prediction modeling with methods from causal inference. And the motivation for that is as follows. Identifying people with bad prognosis is very different from identifying the best course of action for preventing a disease. And the type of prediction models that we've been looking at, like Q-risk, for instance, they can inform us that someone has a bad prognosis and therefore something needs to happen, but they can't tell us what needs to happen. And that's because they do not embed any form of causal inference. If we do embed causal inference in prediction models, then we can actually start making predictions under hypothetical intervention. So explore what would happen if, for instance, we would give Joe antihypertensives, which is the typical question that a GP or any clinician would have, right? If we want to inform clinical decision making, this is the kind of inference that we need. So this moves away from the threshold-based decision making that we mentioned earlier and enables users to compare and contrast different intervention strategies, including, the scenario doing nothing. So this is quite exciting and a new development from the last 5 years, I would say, in the prediction modeling world. We had a really nice workshop a couple of years ago in Leiden, organized by Nan van Geloven at the Lawrence Center, where a community of researchers working on this type of new prediction models, causal prediction models, came together and discussed outstanding challenges and issues. So this is challenge 2, developing risk prediction models that can make predictions under intervention. Like I mentioned, this is an emerging area, and I think we're making good progress. And the first models that actually do this are being developed and brought to practice as we speak. So this brings me to my final topic, which is implementation and impact. So there was a really nice paper published just, I think, 2 months ago now, from a Dutch group. So the first author is called Banafsheh Arshi. The group is from Maastricht, and they did a bibliographical analysis, bibliometric analysis of the literature on prediction models. And they estimated that the total number of published prediction modeling studies is now bigger than 270,000 since 1950. This is an enormous number. And the number of new model development studies that are published every year now is about 10,000. And that number is growing, obviously. And you can see from the graph that for a very long time, this was not a very topical area. But in the last, I would say, 15 years or so, it has really taken up. And there's so many new models being developed and published nowadays. The problem is that most of these models never progress beyond that stage of being developed. And sometimes there's a form of validation or external validation that takes place. So here's a review from models in obstetrics. So these models would typically predict outcomes like preeclampsia, preterm delivery, gestational hypertension, things like that. And the authors, and this was published in 2016, a while ago now. So the authors identified hundreds of models in this area But they also found that the impact of these models on clinical practice was never evaluated, not for a single model. And therefore also, no models are currently recommended by clinical guidelines. Now, this was in 2016. It might have changed now, but I'm afraid that things move very, very slowly on this front. And I've seen a number of other reviews reporting kind of similar results also more recently. So here's one from 2021, and this is in psychiatry. Again, a very large number of models, and only one of them had been implemented in clinical practice. So we undertook a survey of recent literature on implementation of AI models, so clinical prediction models, but also other data-driven models. And this was published in the Yearbook of Medical Informatics 2024. So we focused on literature that was published in 2022 and 2023, and that explicitly reported on implementation of clinical decision support using AI or machine learning. And a number of those AI machine learning models were prediction models, but there were also others. So we found a total of 31 papers, including several reviews, and we categorized them into 4 groups. So one group of papers was about the use of implementation theories and frameworks, use and development of theories and frameworks. One group, the second group was about stakeholder perspectives. Then there was a group about basically pilot studies, implementation feasibility. And the final group was technical infrastructure to support implementation of this type of model. Now, the first very interesting finding here is that the majority of papers, 22 out of 31, was about stakeholder perspectives. So that's what most of these papers did. So let me tell you a little bit more about the things we found. So very few studies used existing implementation theories and frameworks. For instance, there's a framework called the Consolidated Framework for Implementation Research, CFAIR. That's based on hundreds of studies. It's not specifically focused on AI or clinical decision support, but that doesn't really matter because it's extremely powerful in general and embeds a lot of experience that from implementation studies. Remarkably, very, very few studies that we found in our area on healthcare AI implementation used these frameworks. Well, to make things worse, when studies did use existing theories frameworks, they often used ones that were outdated. So we found studies, for instance, that used the Technology Acceptance Model, TAM, which was published in 1989. There is a newer version of that model, which is much, much better and much more up to date. It's called UTAT2, stands for Unified Theory of Acceptance and Use of Technology, version 2. That's from 2012. And I think there's no reason to use the old STEM model because there is UTAT2. I mentioned most studies, 22 out of 31, assessed the perspective of stakeholders on healthcare AI, but typically prior to the development of a concrete solution. So these would be surveys, for instance, given to clinicians asking their opinion about healthcare AI in general. That's not to say that that's not useful. I think we need to know what clinicians think about AI. But I think there's also limited value as long as people haven't got the experience of working with a particular system and seeing what that system actually brings to their clinical practice. The other thing to note here is that those studies typically focused on clinicians and other stakeholder groups were very poorly represented. So think about, for instance, policymakers, people in other executive functions, commissioners, insurers, patients, you name it. And then there were very few studies that evaluated the feasibility of healthcare AI implementation, and also very few studies that described the technical infrastructure required for healthcare AI implementation. So if we try to summarize, if we go back to the learning health system and try to summarize what we found here, is that On the left-hand side of the diagram here, the side, the data to knowledge flow side, where we develop and validate prediction models, I think this part of the learning health system is very well documented. There's excellent methodological guidance, and there's really, really good reporting standards like the tripod plus AI statement. But if we go to other parts of the cycle, things are very different. So when it comes to embedding these prediction models in clinical systems, that's something that is very rarely documented. There's no guidance, I think, on how to do it, and there are no reporting standards. Similarly, implementation of prediction models in clinical practice is rarely documented, and as far as we've seen, existing frameworks and evidence are not being used. And then finally, going to the bottom side of the cycle, studies of user experience and acceptance are rare, and studies of impact of these models on processes and outcomes are extremely rare. So there's quite a bit that needs to improve here. There's one side of the cycle which is in a very good shape, you could say, but the other part of the cycle are not, and that's definitely something that needs to change. So that's my third challenge: improving the conduct and reporting of translational studies in healthcare AI. So we spoke about risk prediction models, global versus local models, about prediction and intervention, and about implementation and impact. A couple of take-home messages. Because health outcomes strongly depend on patient populations, measurement procedures, clinical pathways, there are no universally valid prediction models. So the first challenge that we have in this field is finding the right balance between developing local and global models. Both are imperfect, I would say, but clearly we can't try to rely entirely on global models. That doesn't work. Going in the opposite direction to purely local models, I don't think is the right solution either. So we have to find the right balance. Then to inform treatment decisions, prediction models should be capable of making predictions under hypothetical interventions. So exploring what-if scenarios like Joe. What will happen if we put Joe on antihypertensives? So that's challenge two, making predictions under interventions. And then finally, the translational pathway for risk prediction models is under-researched and under-reported. And this is something that we definitely need to improve, because otherwise this field is never going to have any impact. So thank you very much for listening. I've listed some papers here from my group. I will make sure that the slides somehow become available, perhaps via the MCPK website. And I would like to thank my collaborators, and thank you for listening.
Thank you so much, Niels. That